Good afternoon, everyone. Hello and welcome to the Medscape program. A special welcome to our virtual audience watching via the Medscape Connect platform. We invite everyone to join the Medscape Live Connect platform by scanning the QR code. It's on the agenda on your seat, and it will also be on the screens. Joining the platform is the method to ask questions. We would really welcome your questions and participation in the polling that we will have during the program, and also following the slides. And we also encourage our virtual audience to ask questions and answer the polls as well. So let's begin. Today we have a pleasure of sharing with you a program talking about integration of IDH inhibitors in the therapy of glioma care. Again, just a reminder about the connection. I hope that everybody has the Wi-Fi connection through Snow, and the password is on the screen. And once you scan using your phone, mobile device, iPad, you can join our polling. And it's the same with the slides and access to today's content, as well as asking questions and polling. I wanted to take this opportunity to introduce our panel. My name is Maciej Mrugawa. I am a neuro-oncologist at Mayo Clinic in Arizona. And I have my panelists, great colleagues and friends, Dr. Yoshi Umemura, who is the Chief Medical Officer and Chief of Neuro-Oncology at Ivy Brain Tumor Center and Barrow Neurological Institute in Phoenix, Arizona, and Dr. Rimas Lucas, who is a professor and Associate Chief of Neuro-Oncology Division at the Lurie Comprehensive Cancer Center, as well as Vice Chair of Outpatient Neurology in the Department of Neurology at Northwestern in Chicago, Illinois. So welcome to our panelists, and we hope we'll have a great time together. So this is our agenda for today. We will start with a little bit of a background. I think that IDH inhibition and the IDH story is not foreign to any of you in this room, but nevertheless, we'll walk you through the story. We'll then discuss some of the challenges that we practicing neuro-oncologists are facing sort of on the ground, if you will. And this will be followed by some cases, real cases from clinic. And we would love to have your participation and your input as well, and your questions regarding those cases. And we'll finish with some concluding remarks. So let's talk a little bit about how did we get here. And the first question that we have for you, to kind of get to know you a little bit and see who is in the room, we would like you to tell us who you are. Are you a neuro-oncologist, neurosurgeon, radiation oncologist, advanced practice provider, academic researcher, or another role? So please scan the code, and we will have the answer in a moment. Excellent. So we have about 11% of neuro-oncologists. We have 71% of others. So that's an interesting who these people are. So very much looking forward to the interaction today with all of you. And let's go to our few introductory slides. So it is not foreign to you that to know that gliomas are generally uncommon. However, in terms of what we do, for us in neuro-oncology, that's all we do. And most of the gliomas that we see in the clinic are unfortunately high grade, and about 45% of these tumors are glioblastoma, followed by astrocytomas and oligodendrogliomas. In general, when you talk about low-grade gliomas, there's about 2,000 to 3,000 individuals every year diagnosed with this disease, and majority of these patients harbor IDH1 and 2 mutations. When you look at the age distribution of these tumors, astrocytomas tend to occur a little bit earlier in life as opposed to oligodendrogliomas, but these are very young people, very young individuals. They're at the prime of their lives, as opposed to glioblastoma, which tends to happen later in life. We cannot forget that low-grade glioma is a chronic disease. It's a disease that currently does not have a cure, and it is really a continuum. And it's also a very much life-limiting and life-altering disease. Despite the fact that IDH mutations confer more favorable prognosis, most patients eventually progress. Just to highlight some of the important facts about IDH mutation for grade 2 tumors, you can see that median overall survival in this disease based on the mutational status is much higher when the mutation is present, in 11.4 years versus 5.6 years when the mutation is lacking. Low-grade gliomas grow over time. The rate of growth is about 10% increase every 6 months, so it's critical for us to continue following these patients long term. And that's exactly what is happening in the clinics. You know, patients are with this disease for many years, and we follow them longitudinally. All of you here know the treatment approaches for this disease. For decades, we had radiation and cytotoxic therapies that we've been using with mixed results. We do have some level 1 evidence from randomized trials that multimodality treatment can improve survival and quite significantly. And treatment decisions in the pre-IDH era were often controversial. I'm not sure after IDH era they're going to be less controversial. We'll see at the later stages of the program. But nevertheless, we used modalities such as observation versus upfront therapy, some salvage therapies, and we were making really decisions for our patients case by case. Molecular pathology changed everything. The fact remains that the molecular pathology research and progress is evolving much more rapidly than clinical research. So we're kind of lagging behind with all this data and all this wonderful information about the biology, but we are not keeping up fast enough in development of treatments for this condition. But we do now have new targeted therapy, an IDH inhibitor that's FDA approved, and that really changed a lot in how we do things. So going back a few years, when I was a fellow long time ago, we used H&H staining, basically histology, to make the diagnosis, and we are heavily relying on the neuropathologist's opinion in terms of what this tumor is and what the grade is. Then in 2016 came WHO classification that really started changing everything. And in addition to conventional histology, we started implementing genetic material, genetic information, molecular information into the diagnosis, coming up with the integrated diagnosis. And then it was taken even a next step further in 2021 when the most recent classification was published with new entities added, new approaches to grading, and new nomenclature. I would like to thank for this slide, to say thank you to Craig Horbinski, who allowed me to use it. This is basically an evolution of WHO classification over the years. Funnily, it also kind of follows my career. In 2000, I was a resident, and in 2007, I was a fellow, and then I was the attending. So basically, at every stage of my life, we had a new edition of the book. I don't know if many of you had been at Dr. Perry's talk yesterday, but he announced that the next iteration of this classification will probably come out in 2027. So stay tuned. So we really don't know where we are going. So Quo Vadis from Latin, where is neuro-oncology going? I think it's going in the right direction, and there's a lot of hope, but I think the next book is probably going to be twice as thick as the one from 2021. So establishing the IDH mutation status is essential not only to the diagnosis, but also to deciding what kind of treatment the patient should receive. Again, recapitulating some of the data from 2007 and 2016 classifications, but just one key message from the most recent classification is that the grading of the tumors is now also based on molecular characteristics. It's not only the histology. So when you look at the 2021 classification, molecular features were used for mostly diagnosis of the adult diffuse gliomas. Then ASCO/SNO guidelines from 2021 also recommended and highlighted the importance of IDH mutation in the treatment of adult diffuse gliomas. And finally, NCCN guidelines are recommending now to test all glioma patients for IDH mutation, as it does have impact on diagnosis, prognosis, as well as treatment recommendations for our patients. I love history of medicine, and specifically history of neuro-oncology, and I got this slide from Dr. Preusser from Vienna, and you can see that the lower half kind of shows the milestones in development of molecular biology with 1p19q loss identification, then its prognostic value in terms of response to chemotherapy, then identification of IDH mutation in low-grade gliomas in 2008, identification of 2-HG that is an oncometabolite, and then finally first studies with IDH inhibitors in humans. And the top of the graph shows you the clinical evolution with mid-80s really mostly dominated by radiation and not having other good options. Then came temozolomide in late 1990s, initially for recurrent anaplastic astrocytomas, and then it evolved into other indications. Then we had studies with PCV in oligodendrogliomas, and then finally a study with the first IDH inhibitor, which then eventually led to the approval of the drug based on the study published in 2023. So this really shows you kind of a nice trajectory over the years, and it also tells you how much time it took for this to develop and to get us where we are right now. Just a brief discussion about IDH mutations and glioma biology. As I mentioned before, 70 to 80% of low-grade gliomas have IDH1 and 2 mutations. The mutant enzymes are responsible for production of 2-hydroxyglutarate, which is an oncometabolite, and this leads to widespread epigenetic dysregulation and tumor growth. It is the molecular status, so IDH molecular status is critical for the molecular diagnosis of astrocytoma, but it can also be used for diagnostic modalities such as MR spectroscopy, where some modalities like this one can potentially detect levels of 2-hydroxyglutarate in the tumor even before the biopsy is done. So I think that's where the future is, that we will be able to assess these tumors even before we have the tissue. There was a wonderful discussion today at this meeting about liquid biopsies and ability to assess levels of 2-hydroxyglutarate in CSF and using it diagnostically as well. So I think there's a lot of potential with multiple technologies to be able to diagnose these tumors even before we have the tissue. So a few words about molecular classification of gliomas, which is now really based on IDH mutation or the lack of thereof. So then you will have the IDH mutated disease and IDH wild type disease. And then based on additional mutations, as you can see on the left side of the graph, ATRX, 1p19q deletion, CDKN2A and B deletion, depending on which molecular variation is present, then you can then classify the tumor either into an oligodendroglioma, either grade 2 or 3, or astrocytoma grade 2 or 3, or astrocytoma grade 4. We are not going to spend time on the right side of the graph where we talk about IDH wild type disease, since it's irrelevant for today. In terms of treatment of IDH mutant gliomas in the pre-IDH inhibitor era, it was a little bit different. Once the diagnosis was established based on the biopsy of a resection, patients were then classified into different categories, either oligodendroglioma or astrocytoma, different grades, and then there were categories, looking at favorable and less favorable, and this has been really beautifully described in this IANO guidelines paper. And for patients with favorable prognostic factors that you have listed on the slide, we would frequently approach it with watch and wait instead of potentially treating them early. However, patients with less favorable prognostic factors, specifically with higher grade disease, would typically be receiving radiation followed by PCV or temozolomide-based treatment. So this was happening until recently, when we did not yet have IDH inhibitors available for our patients. But now consider these possibilities and clinical scenarios for the use of an IDH inhibitor. So in the upper left, the classic indication would be to use an IDH inhibitor following a resection, but before radiation and chemotherapy. And that's the indication that we currently have for this particular treatment. However, we know that in clinic we see all sorts of different scenarios. So for example, we see patients who progressed after being on an older class of IDH inhibitor. And what do we do then? We have patients who have been treated with ivosidenib and progressed. And what do we do then? Or they're already on ivosidenib and they're fine, but should we be switching them to the vorasidenib? So that's another possible scenario. We have patients who have had prior resections. What would we do in this particular case? There is a huge debate about enhancing and non-enhancing disease. And would it be appropriate to use IDH inhibitor in the case of patient with enhancing disease? And finally, the biggest question, maybe not the biggest, but one of the more important ones, is grade 3 disease. What do we do with patients who have IDH mutated tumors but are higher grade? And would it be possible to use these IDH inhibitors in this setting? I want you to remember this slide because next we're going to do a question that's going to basically ask you if you have ever considered some of these scenarios. So let's go to the question, and can you please scan your QRC code, and we'll wait for a few seconds to see where we get with this. Excellent. So 61% of people that didn't really consider many of these clinical scenarios. About 20% of you considered one, about 12% two, and about 8% three or more. So certainly that indicates that it has been crossing your mind that these scenarios do happen in clinic, and you've been debating what to do in this possible clinical scenario. So thank you so much for participating in this poll. So let's briefly talk about the INDIGO study, which led to the approval of vorasidenib for patients with IDH mutated gliomas. As you know, key eligibility criteria included patients 12 years of older with IDH 1, 2, grade 2 oligodendroglioma or astrocytoma based on the 2016 WHO guidelines. Prior surgery was allowed, prior surgery only, and patients needed to have measurable non-enhancing disease as a target. This needed to be confirmed by a blinded review. And patients did not have to be in the need of immediate chemotherapy or radiation per assessment of an investigator. So it was considered to be safe to do something else rather than radiation and chemotherapy. This was a double-blind study and was randomized on 331 patients. Vorasidenib was given at 40 milligrams versus placebo, and the distribution of patients was quite equal. Patients were taking the medication orally once a day. And then the crossover from placebo to vorasidenib was permitted when radiographic progressive disease was documented and centrally confirmed. And as you remember, the primary endpoints for this study were progression-free survival as well as time to next intervention. And these are the plots from that I'm sure everybody has now embedded in their brains, showing that progression-free survival was significantly higher in patients receiving vorasidenib versus placebo. And similarly, time to next intervention was not achieved in the vorasidenib arm and was 17.8 months in patients on placebo. So the results of this study resulted in the approval of the drug. Few words about safety signals, generally very well tolerated with some abnormalities seen mostly in terms of liver function. So following LFTs is critical. Also, a very small percentage of patients with hypertension and decreased neutrophil count. But when you look at the treatment interruption due to side effects on vorasidenib arm, about 30% of patients had interruption. But eventually resumed the treatment. Those reductions were uncommon, about 10% of patients on the experimental arm, and discontinuation also very low number, single digits, 3.6%, and no fatal events on the study. So safety data looking really good. One thing that I wanted to mention specifically about the subgroup analysis has to do with seizures. As we all know, patients with low-grade gliomas frequently suffer from seizures, and in the INDIGO study it wasn't different, but patients were allowed on the study only if they had well-controlled seizures. Anti-seizure medications were up to the treating physician, and patients had the diaries where they would report the number and severity of seizures. And in the subgroup analysis, patients with more than one reported seizures were taken into account, and then seizure activity was calculated using a negative binomial model, which is currently used in epilepsy studies. And the model was also adjusted for baseline seizure number and stratification factors. And as you can see, the number of events on treatment arm in terms of seizures was significantly lower than on placebo arm, with the rate of on-treatment seizures per person also being significantly lower, with about 64% reduction in seizure frequency on the vorasidenib arm. And when you looked at seizures per person per year, 2.8 less seizures, fewer seizures per person per year on the study arm. So this is a very important finding, because we obviously use these drugs not only to control seizures, but also to make difference in patients' quality of life. And one of the main morbidities in this disease are seizures. Just a quick point. At the recent IANO meeting in Prague, Dr. Ruda from Turin presented her data on 55 patients, also looking at seizures in patients on vorasidenib, and she discovered a very early onset of activity of vorasidenib, and this was also correlated with the levels of 2-hydroxyglutarate in the plasma going down. So I think we need more work in that space, but nevertheless, I think this is very relevant for the discussion of one of our cases that we will be talking about in a few moments. So as I mentioned, based on the data from INDIGO, this is a seminal paper from New England Journal of Medicine from August of 2023, and a year later, the drug vorasidenib was approved for use in the clinic. Of course, since the approval, and it has now been 15 months, I believe, right? I haven't counted, but I think that's about right. The approval of this medication is not quite global. However, it is available in the United States, in Canada, in South America, most of Europe, Middle East, Australia, and Japan. In terms of the access to medication and sort of adoption rates, looking at some surveys, it seems that academic centers, NCI designated cancer centers in the United States have a higher rate of adoption of this treatment as opposed to more community-based practices, which is not surprising. And in terms of US versus Europe, it seems that the uptake was a little bit faster in the United States, and access to vorasidenib was a little bit more limited in Europe, especially at the beginning, but I'm sure that it has changed by now. So as you can see, the drug is available throughout the world, and I think there will be additional territories added to this map. So we have another polling question for you. When considering an IDH inhibitor for an eligible patient, what is the most important factor that influences your recommendation? Is it age of the patient, tumor size, tumor location, prior treatments, benefit to risk ratio of the drug, guideline recommendations, or they're all equally important to you? So thank you for participating in the poll. Okay, very good. So it seems like the age has been removed, which is interesting to see how we evolved over time. Tumor size, about 4% of you, prior treatments, benefit to risk ratio, a high number of you value that, and that's exactly what's happening in clinical practice. And guideline recommendations, as we discussed, are important, and for many of you, all are equally important. And I think that's right, that we take all of this into account when making those decisions. So thank you for the poll. So just getting us to the cases, so what do we do in clinical practice today? So in the sort of post-IDH approval, so patients have a biopsy or surgery, and they are diagnosed with a grade 2 disease, and if they had a complete resection, we typically would offer watch and wait or vorasidenib, depending on the scenario. If there is residual disease and there's no need for immediate radiation or chemotherapy, then also vorasidenib would be offered. And then in high-risk patients, and high risk is in quotes here because high risk is not very well defined. You know, high risk for different people can mean different things, but generally speaking, high-risk patients would typically be treated with radiation followed by either PCV or temozolomide. So many questions remain, and this is going to be a nice transition to our cases. So who do we select the IDH inhibitor therapy for? And when are upfront therapies appropriate, so radiation and chemo? Can we use IDH inhibitors upfront? So let's say the patient didn't have any surgery, just a biopsy, and can we use them upfront? What do we do with grade 3 tumors? And the whole question about non-enhancing versus enhancing disease. What is the best salvage therapy for our patients? What is the best combination therapy? And what practical criteria could be used to make decisions in real time? And that's sort of where our tumor board comes into play. And I'm sure many of you have tumor boards at your institutions. And today we are one big tumor board when we're going to start discussing our cases in the next few minutes. In terms of what's next, so we now have the approval, we know what it's for, but we are evolving, right? So there's many studies currently ongoing, combining vorasidenib with different agents, with temozolomide, pembrolizumab. There are studies in grade 2 disease, grade 3 disease, and all sorts of phases of studies, including phase 1 and phase 2 and phase 3 studies. So Vora is being tested in multiple different studies. We queried clinicaltrials.gov on November 14th, so this is pretty fresh in terms of what's out there. But let's not forget that there are also novel IDH inhibitors that are also being tested in clinical trials. And there's many phase 1 studies with some of the earlier drugs, but there are also phase 2 studies looking at different drugs and also different indications. And this list, of course, is evolving, and we're going to see more and more studies, which is extremely exciting for our field and for our patients. So in summary, we now have a new treatment option for IDH-mutated gliomas. IDH inhibitors represent a novel class of oral targeted therapies. Clinical trials show promise, so we now have a robust evidence that this treatment works and improves progression-free survival. We know that it does have impact on tumor growth, delaying progression of the disease, slowing down the growth rate of the tumor, and potentially also offering benefits in terms of seizure control and other quality of life measures. These drugs have very good safety profile, and side effects are very mild and well tolerated and very easily managed. And the treatment landscape is evolving. So as I was able to hopefully I was able to show you that both vorasidenib and also novel IDH inhibitors are being tested in this disease, and I think the future is bright. So now we're going to move to the next part of our program. We have the data that I shared with you, but how are we doing in the clinic? How are we using IDH inhibitors in the clinic? And I'm going to ask my colleague, Dr. Umemura, to get us to the next phase of our program.
Thank you, Dr. Mrugala. So I'm going to start off on talking about some of the challenges that we face in real world on the ground caring for these patients and things to consider. And I'm going to share this conversation with Dr. Lucas as well. So I'll start with the logistical hurdles. So there are many things to consider, especially because of the age group that we are talking about in this disease. They are uniquely young. They are 30s, 40s, sometimes 50s. So even thinking about basic things, I myself moved 3 times in my 30s. People who are not in one place, they move places, they don't have primary care doctor. So continuity of care is an issue, access to care is an issue. They might not have a say on where they live in the time of their career. And other things are, seizures are very prevalent in this population because of the IDH mutation, as Dr. Murgala pointed out. And people who have had seizures cannot drive. And not everybody lives in New York City or places that have public transportation, or Phoenix for that matter, where we live, where there is Waymo.
Thank God for Waymo.
Yeah, exactly. But people don't always have that. So maybe they can't get to places. So there are many things that we end up dealing with specifically for these patient population. And also a lot of them are starting their family. I have been to a couple of my patients' weddings, and they are just starting their families, and things about fertility management and how do we preserve their fertility. Can they get pregnant? These things are very important to their life. I think we have some international audience here today, and this drug is not yet available, or not just vorasidenib, but IDH inhibitor is not available in every country. So what happens in those countries? And on top of that, I don't know about all of you, but I am not really good at taking my vitamins. And I'm sure there are people who are not very good at adhering to their medications as well. And when you are in transitional state of your life, you don't always have medical coverage and insurance. So all of these things come into play, and we don't just talk about disease and treatment, we end up talking about how they manage their life, how they manage their family planning, and all of these things come to play. And I'm gonna pass this to Dr. Lucas.
Thank you, Yoshi. So one of the things that I wanted to highlight in this slide is a practical clinical aspect that has direct relevance in some of our discussions that we'll be covering in a moment. And so this is this concept that Dr. Murgala had mentioned earlier of enhancing versus non-enhancing disease. And for myself, I think of enhancement in these infiltrating gliomas as a cheap proxy for an increased complexity of the tumor and probably an increased heterogeneity of the tumor. And the reason why this is important is it may guide some of our clinical management decision making. And I think all of us who care for this patient population become a bit more worried when we're seeing these enhancing tumors. Now, this has particular relevance when we're thinking about IDH inhibition as a class. And the reason why is in early phase studies, there seemed to be a signal that with the IDH inhibitors that we don't get as good of a clinical benefit as in the enhancing disease as we get in the non-enhancing disease. Now, there are some exceptions to the rule. So when you saw that list of medications earlier, olutasidenib has some data saying that there may be a greater degree of benefit than one would anticipate in the enhancing tumors, but it's still from a limited amount of early phase data. And so now we're going to shift over from the background into what becomes much more interesting, and this is discussing real world cases. So this is where the boots hit the pavement, if you will. All right, so if you want to participate by asking questions, please feel free to scan this QR code. This is the same code as earlier, and ask away. And I think that'll make the discussion a little bit more dynamic. All right, this is a real case study, patient of mine, 49-year-old woman who had new onset seizures 10 years ago. And I think this 10-year aspect really brings home the concept that this is a disease or a set of diseases with a very long natural history. So we're thinking about a long, years to decades long time frame as opposed to months to brief years in the setting of some of our higher grade tumors. Patient underwent a craniotomy with a gross total resection about 10 years ago. Pathology demonstrated an oligodendroglioma, WHO grade 2, and then the patient was followed clinically and radiographically. And so this is an appropriate clinical management. When there was evidence of recurrence, the patient underwent an extensive subtotal resection. This is about 3 years after being followed. If you think back to the indigo data that was presented, in the control arm, what you could end up seeing is the time to next intervention was somewhere in the 17 to 18 month range. That means if patients were getting placebo, we were able to kind of drag our feet for a long time before we actually had to do something. And this for me is kind of a recapitulation of that in that clinical real world setting. At the time, however, of that extensive subtotal resection, the pathologic grade had increased to a grade 3, and this also reflects what we can oftentimes see. The patient received temozolomide because she was concerned about the toxicities related to radiation therapy, and so this is after an extensive discussion, and then after that she was followed again clinically and radiographically. Everything was nice and calm until seizures recurred about 6 years after the completion of temozolomide, and the patient was then placed on anti-epileptic medications, so there was adjustments of anti-epileptic medications. This was conducted by her tumor-related epileptologist. She received levetiracetam and cenobamate. However, the seizures persisted, and when imaging was performed, one could see a pretty clear area of increased flare without any associated enhancement. And we can see here that its relationship to the motor strip can be a bit worrisome with regards to what could be done. So now we can pause and think about what we would, what treatment strategy would we prioritize for this patient? Is this somebody we would want to do a re-resection? So she's already had 2 surgeries. Tumor is growing posteriorly in towards the motor strip. Should she get radiation now, which she is naive to? Should there be a temozolomide re-challenge, or should we use another alkylating chemotherapy such as CCNU? Should we use IDH inhibition or clinical trial if available? All right, so we can see that there's kind of like this mixed bag of responses. Temozolomide, IDH inhibitor, combination of temozolomide with IDH inhibitor, and more surgery. So I think this really reflects the way that we discussed this patient's case at our own tumor board, where a wide variety of different options were thought to be legitimate pathways forward. And the reason why, for me, this is a particularly interesting scenario, in the past, I would have probably viewed the seizures as something that I can just control with some anti-seizure medications, or in this case, a tumor-related epileptologist can control probably pretty easily. And then we would sort of take the seizure aspect off of the table, and we'd say, okay, what are we actually going to do to deal with the tumor? However, in the current contemporary era, I start to think about the role of systemic therapies and non-systemic therapies, things like radiation and surgery, in how they're controlling seizures. And for myself, I would probably say I was an advocate for IDH inhibition in this case, more so than for radiation because of the patient's disinclination towards that modality, although I was open to the idea of surgery as well. And I guess, Yoshi, what are your thoughts in this scenario? What would you guys have done if she came to your institution?
I think seizures can definitely be a sign of the early progression before you can see it on the radiographic changes. And I think before the vorasidenib approval era, even when I was in training, I think we talked about restarting temozolomide, for example, to try to have some cytotoxic effect to the tumor to treat the IDH mutated cells. But now that we have vorasidenib available for patients who feel that they are on the fence about cytotoxic therapy or radiation, I think it is a very good alternative for those patients, better than nothing. I know a few epileptologists who also favor that as well, rather than going up and up and up on seizure medications when they're on 3 medications that can make them tired, for example.
Yeah, and I feel sort of the same way with regards to using a tumor treating agent to help bring down the seizures. Machi, at your institution, would you guys operate on this case? Would you?
So great question. So thank you for bringing that up. I think that what worries me a little bit about this case is the grade of the tumor, because we kind of glazed over it a little bit, but we now know that she's grade 3. And she's had this disease for a while. So while I'm not necessarily opposed to trying an IDH inhibitor, I feel like radiotherapy would be a more conventional approach to this particular case, and potentially preventing a conversion into grade 4 disease. However, the interesting idea could be to potentially, it sounds like the surgery, given the location, is not the ideal approach because she has already had a couple of craniotomies and it could result in neurological deficits. But what if the IDH inhibitor was used first? We would witness potentially reduction in the volume of the disease and maybe improvement of the seizure control. And then do radiation after, maybe allowing for a smaller radiation field and kind of diminishing the side effects from radiation. So that would potentially be another option, again, very unconventional. However, and then radiation would sort of, seal the deal, if you will, in a grade 3 setting.
Yeah. So it's interesting because the data in grade 2 tumors demonstrates that there is some decrease in the volumetric size of the tumors, but it's not substantial, right? So you're thinking something like in the 3% range, and it takes a long time. I think this afternoon there was an interesting presentation earlier about the role of photons versus protons in this type of a disease. A group from the Netherlands demonstrating that in grade 3 tumors, proton therapy seemed to be inferior to photon therapy, presumably because you're not treating as wide of a field, you're not getting all the cells that are scattered further away. So, I don't know. It's an interesting, tough case.
It certainly is, and there's also some data indicating that radiation can sometimes also improve seizure control. So it would, if the patient was not opposed to radiation, sounds like she is opposed to radiation, and that might also be sort of a selling point. That we're dealing with a high-grade histology. You're having seizures, we can potentially address both problems with the same modality of treatment. Would you consider giving her more chemotherapy? So she completed 9 cycles of temozolomide, more, about 9. So if you were to do radiation again, would you do radiation with concomitant temozolomide followed by temozolomide? Would you do radiation alone? How would you approach that?
Yeah, that's a good question. So I'm not a huge fan of the temozolomide re-challenge, and I think part of my thoughts on that are it's nice to sort of potentially mix it up. There's preclinical data in GBM, so not in grade 3 oligos, where if you treat with radiation temozolomide and then you subsequently retreat with temozolomide, you really don't get any bang for your buck. But if you treat with CCNU in that setting, the tumors are still relatively sensitive to that. So I think if I did an alkylating chemo, I would do CCNU in this case, or PC, since it's an oligo. I think it would be reasonable if I was going to do radiation to maybe give it an extra, boost with that. And I think in general, we're all comfortable using these drugs and people can tolerate it well. So I think that would be a rational approach.
Rational approach, yeah, I agree. So this is actually leads us very nicely to the question from the audience. So thank you for the question. So how you are currently treating grade 3 IDH mutated gliomas, and what data would IDH inhibitors need to show in this setting to be adopted?
So for me, grade 3 oligos, if they're de novo, if they just had the surgery, my typical recommendation is going to be for radiation plus alkylating chemotherapy. At my own institution, I'm probably the one voice who shouts in favor of a PCV or PC-based approach. I think Andy Lastman's retrospective study of PCV versus TMZ helps support that. I think the POLA study that was from the French group also supports that. Now I can say a number of my colleagues whom I greatly respect would choose TMZ because it's a lot easier and a little bit better tolerated. So that would be my usual recommendation. Now there are exceptions to the rule. If the patient has a grade 3 oligo and it's a gross total resection and they're young and they want to maintain their cognitive functioning, I would at least bring up the idea of using IDH inhibition. But I would be explicit in saying, here's all the things that we don't know. Here are all the gaps in our knowledge. And I would also be explicit in saying, this is the standard treatment using radiation plus chemo. It's been shown to clearly improve survival when compared to radiation alone. So I rely on like RTOG study and the UOGC study to help support that kind of an argument.
Thank you so much. And what would you like to see in this setting for the IDH inhibitors to be adopted? What kind of study would you like to see? What endpoints would you design?
I don't know. Yeah, so I think this is going to be a tough type of scenario. I think having an endpoint that in oligodendrogliomas, I think we're comfortable now with PFS or time to next intervention as solid endpoints in this disease. We can't, design another, CODEL Part 2 and wait another, number of years to get answers. So I think something along those lines would be fine. I'd actually be kind of interested in radiographic volumetric endpoints. I think we can get quick readouts on that, so it's a cheaper way to get to answers, and I think it helps support the idea that there's biologic relevance to what we're doing. So for me, those would be interesting. And then if you could maybe take that the next step further, you mentioned 2Hg MR spectroscopy, maybe supplementing with that, or you could think about whether there's a role for amino acid PET as another way to measure whether we're responding or not.
Yeah, all good, great ideas. Excellent. So let's go to our second case, and Yoshi is going to walk us through.
All right, sounds good. Okay, so the second case, also a real patient, 42-year-old man who initially presented with left frontotemporal tumor, which you'll see in a second on the next slide. This patient's tumor was deemed not feasible to be resected, and the patient only had biopsy because of the diffuse involvement of his brain. The patient received upfront radiation and is on chemotherapy, completed 7 cycles out of 12, not yet done, the planned 12th cycle, and the imaging is stable. And the diagnosis is grade 3 astrocytoma with IDH mutation. And here is the imaging that was taken right at the time of the diagnosis, and it's not shown here, but just assume that it has been stable. There's no question, is it a little more, is it a little less? It's stable. So you can see it is quite extensive of the disease involvement that you can see in the non-enhancing disease, mostly involving the left frontal lobe and extending over to the right frontal area, and with very not much enhancement, even though it is grade 3. So in this, in this case, of grade 3 tumor with stable MRI, what would you recommend after finishing the 12 cycles? So you have 3 more months to go, and the patients are probably thinking, okay, I'm almost done with chemotherapy, and you may start talking about what's gonna happen next. And knowing the tumor is still extensive, what would you do? So the first option is to stop temozolomide at the 7th cycle, perhaps because it's more than 6, and you move to surveillance, or you continue temozolomide alone past 12 cycles, and then you have IDH alone option, and temozolomide past 12 cycles, and further resection. Oh, do I press?
Nope.
Oh, we're doing show of hands.
Show of hands.
Okay.
It looks.
So we are going to be show of hands. So how many of you would stop temozolomide at 12 cycles and move to surveillance? Okay, a few. Continue temozolomide alone, but you're going to do more than 12 cycles. Okay, not that many. IDH inhibitor, switching to IDH inhibitor as a maintenance, as a monotherapy. Okay, a few. And temozolomide past 12 cycles now combined with IDH inhibitor. Okay, all right. And further resection. Okay, all right. So I feel it's quite a bit of a scattered response. It's good to see that there are different opinions. So I would say in this case, I think that one of the most common questions that we get in clinic is, what do I do now at the end of the treatment? The tumor is still there. You are telling them this is not a curable disease. And the most common question is, what else can I be doing? Can I be taking this? Can I be taking that? What else can I be doing? Especially when you tell them about surveillance. And for standard of care, usually we would recommend surveillance. I would say continuing temozolomide alone past 12 cycle is, I would personally would not recommend it. I have met neuro-oncologists who I do respect, multiple that have done this. I think this is from an era probably before my training era where temozolomide was.
Mine and Machi's era.
I'm a little bit behind you guys. In
36 cycles of temozolomide.
I think I was actually I was in the era when things were kind of shifting more from 12 and then to 6. And just knowing that there may be more mutations that can occur, and also you can be suppressing the bone marrow, I typically would not recommend that. I would say there are kind of different opinion of if you should do IDH inhibitor and what that can do to the mutation. We don't have a long-term data. I understand that, but I feel that that is a reasonable thing. I personally would sometimes do that when there's a lot of disease and patient want to be on IDH inhibitor. I usually would not tell them like, no, you can't do that, and I would try to get the drug for them. If the tumor was not resectable, deemed not safe to resect on the initial disease and it has not changed, I usually would not challenge that necessarily unless I disagreed with that assessment. I think the combination is yet to be answered. I think there are different opinions if that is beneficial or not, and because that is ongoing in clinical trial setting, I think it's reasonable. Some physicians are doing it. I personally do not do it myself. How about you guys? Do you have a favorite option, Dr. Lucas?
My favorite option is to watch this.
Yeah.
And I think that I agreed that would be the standard approach. And I did grow up in the era where we used to give more and more temozolomide, and I think it was the wrong thing to do because of that bone marrow suppression that closes doors for future therapeutics, or the ability to tolerate future therapeutics. I also had that same kind of a worry about the increasing mutational burden within the tumor and potentially making it more aggressive over time. So I think at this point we don't have adequate data saying that IDH inhibition is an appropriate thing to do here as a maintenance therapy. I think it's an important question for us to try to answer, but I would probably drag my feet on doing it until we actually had some hard and fast evidence to support that.
I think it really highlights, just changing of the practice is okay. I think when we're focusing on evidence-based practice, the change of practice does happen as the new evidence comes out. And I think it's really important to highlight to shift when needed. I
agree. Great discussion. Since we only have a few minutes left and we have one more case, let's just jump into the last case. So this is also a real patient from my clinic, a 49 years old man who presented with facial numbness and drooling. MRI, which you will see in a moment, showed a right frontal mass with increased perfusion, and EEG was also positive for electrographic seizures. The patient underwent a biopsy of the lesion. Resection was deemed to be too risky by our neurosurgical team. A patient was also placed on anti-seizure medications, required 2, with good control of seizures, and the results of the biopsy showed an IDH mutated WHO grade 2 disease. So this is the lesion. You can see abnormal T2 FLIR signal abnormality. This is a pre-biopsy MRI, no abnormal enhancement. I'm not, showing the post-contrast images. It looks like we are having some issues with our poll, so we will do what we did with the last case. So in this particular case of the grade 2 tumor, after the biopsy, potential management option would you consider upfront for this patient? So what would you do? Would you radiate followed by chemo? Would you use IDH inhibitor alone? Would you do IDH inhibitor with surgical resection, then IDH inhibitor, and then finally surgical resection followed by surveillance? So first, it's working. Oh, okay. Okay, thank you so much for your responses. So IDH inhibitor alone, a high percentage of you said that, surgical resection, then IDH inhibitor. Very few would do radiation followed by chemo. Excellent, very good. So we were struggling with this case, I must say, at my institution. There were multiple different opinions what to do with this patient after the biopsy. We almost did radiation, but then we put the brakes on it, and our surgeons were not keen on going back and doing a resection. And then the idea of using an IDH inhibitor up front came about to see if potentially decreasing the bulk of the disease can be achieved. And then if that's the case, would then resection be done? Or potentially if resection cannot be done and the patient remains stable, on the IDH inhibitor, we can just continue. So that's what exactly happened with this patient, and he's currently on vorasidenib a couple months into it, so I can't really tell you yet what is going to happen, but that's what we did. But I'm interested in opinions from my colleagues. What would you do with this patient if it was up to you and your tumor board?
So at tumor board, I have certainly heard from our neurosurgeon colleagues, oh, can we do IDH inhibitor to shrink it first? And I often would tell them we shouldn't assume that it does because as Dr. Lucas pointed out, it often does not, or it may not be enough to say. And it also may take a lot of time. Exactly. Right. So I would tell them that, I think the purpose of using IDH inhibitor would exactly as Indigo study showed, to delay the time until the intervention with radiation and chemotherapy, which means a lot for some patients to not have to do that immediately. So I think that would be the clarifying point to make.
Yeah, I think for myself, I'm a strong believer in the value of surgical resection. I think all of the recent work from Rano Resect, as well as earlier work by Mitch Berger and Hughes Defoe, supports the concept that getting out a lot of tumor is of benefit from a survival perspective. So I would try to put that as my first option. Now, this is with the caveat of me not being a neurosurgeon, and it would depend on whether my neurosurgery colleagues felt that they could have a truly extensive resection, either gross total or near gross total. If it was felt that they couldn't do that, in that scenario, then I would go with the IDH inhibitor. Before I would do the radiation temozolomide, and then just push that down the road as much as possible.
So it sounds like we did the right thing. But it took a lot of discussion. It certainly took a lot of back and forth, also with the patient, because the patient was really looking for guidance from us. They were not necessarily opposed to getting radiation. They were opposed to getting surgery, but they were open to the idea of trying the medication, and that's what we did.
But I think you have the luxury of time in that case, which is nice too, right? This is different than if it was a
with
glioblastoma.
The grade 2 disease, then you're much more comfortable doing so because you're not fearful that this is going to convert or start enhancing or become a higher grade disease. So I think we have a couple of questions. We have 2 minutes left, so maybe just one question. What about recurrent progressive IDH gliomas? Have you used IDH inhibitors, or what data would you need to use these agents in this setting?
I have used it in a setting where the recurrence was one of those instances that you can't see it immediately. Comparing the images over 1 or 2 or 3 years, that you can see things are clearly becoming more bulky in a very, very slowly progressive way, and patients are reluctant to immediately go back to radiation chemotherapy rather than waiting longer and longer. We often, not often, but in cases that would consider IDH inhibitor alone to see if we can prevent further growth or faster growth. I think in cases where things are growing rapidly or become very enhancing between 2 scans, for example, I really would not favor doing IDH inhibitor alone because just even from Indigo trial data, you can see that the change in the volumetric does not occur immediately. I think in those cases, cytotoxic therapies are needed.
Yeah, I have a similar view as Yoshi on this one. I think for the tumors that look very aggressive, where that's cheap proxy of enhancement, making it seem like it's a nastier, higher grade tumor, then I would go with the radiation chemo, or chemo if they're already radiation exposed. But I think the scenario of patients who have gotten radiation and chemo ages ago and now have this somewhat indolent growth of tumors, for me, IDH inhibitor is kind of the go-to. Now, the difficulty is we don't have strong data to support that. So we have case series, so David Campson had a nice case series with IVO, demonstrating that there was radiographic improvement over time. And so I use that kind of information. It is aligned with the FDA label, so I think it's not difficult to get it approved, but it isn't supported by any phase 3 data, to my knowledge.
Thank you so much. Well, I think we came to the conclusion of our program. I wanted to thank my phenomenal panelists. We hope that this discussion was helpful. We tried to show you, and I'm sure you are dealing with the same issues in your clinics, what's happening in the world after the sort of in a post-IDH inhibitor approval. We thank you for your question, for the participation in the program, and also thank Medscape for really organizing this and supporting this initiative. And before we finish, just wanted to do the plug for a program, but the slide disappeared. Here we go. So if you would like to be kind of more engaged in the contemporary glioma care, innovation, collaboration, transformation, please scan this code at the bottom of your slide. This is a great initiative. It's data-driven, and it will really help you follow what's happening in our field and how progress is being made in real time. So please join me in applauding our wonderful panelists today, and thank you for your participation. Enjoy the rest of your meeting.
Thank you.